We're going to begin the new content starting with congestive heart failure. So, who wants to tell me what congestive heart failure is?
Is that a blocking of the arteries so that the muscles aren't contracting correctly?
Well, it is that there's a failure of the pump. It doesn't have to be from an MI, it could be, or a block of the arteries. For some reason, the heart is not pumping enough oxygenated blood to the body. So it could be a cause from a previous heart attack or coronary artery blockage, or it could be caused by hypertension over time or some kind of viral infection or congenital defect or even lung diseases. But essentially, it's that the heart can no longer pump effectively to get the oxygenated blood to the rest of the body. So we're really talking about cardiac output. We want the heart to eject enough blood during systole, during the time when the ventricles contract, in order to get the proper amount of cardiac output so that our body gets enough oxygen. So cardiac output equals heart rate times stroke volume. So I'm not sure if you've ever seen that before, hopefully. Essentially, that means that the amount of blood that gets ejected from the heart in a minute is based on the amount of time the heart does that, and that's the heart rate. That's what you're feeling with the pulse is ejected blood. And the stroke volume is the amount of blood that's ejected each time. So obviously heart rate is easy, that's the pulse. The other part of this is stroke volume, because these are the things that we target in terms of medications. How can we bring stroke volume up? How can we bring cardiac output up? I mean, we can only bring the heart rate up so high without hurting the patient. So we don't manipulate the heart rate as much as we try to fix stroke volume. And so we have to understand what determines stroke volume, and there's three parts to it that are listed here. The work of the heart is determined by the preload, contractility, and afterload, and these are our medication targets. So preload is the amount of fluid. So I always say preload is P, fluid, that the heart has to work with. If there's extra fluid in the body, then the heart is going to have more work because it's going to have to push more fluid around. So that's one thing we can do to target heart failure, is we can manipulate the amount of fluid that's there. The other thing we can do is contractility, which is really the muscles. So we can try to make the muscles work better and more effectively. And the other part is afterload, which is arteries, which is essentially the blood pressure. If the person has a very high blood pressure, it's like adding extra weight for the heart. It's more work, more resistance for the heart. So if our heart isn't working very well, the pump is not very effective, then the best thing we can do is make it easier for the heart to work by trying to get rid of extra fluid and by bringing the blood pressure down and by trying to get the muscles to contract better. So we'd have to know what are
So I just have a quick question.
Sure.
So with the preload, is that where we would want to add like a diuretic?
Exactly.
Okay. All
So
right. I'm
that'll
just trying to
be,
put everything together.
oh no, perfect. So if we can get rid of fluid, we would use a diuretic for congestive heart failure, and then we can use a lot of our antihypertensives to change the afterload. And then there are medications that promote muscle contraction, help the heart contract better. So we can, those are all of our medication targets. So in order to be sure that we know that the patient is getting better, because we always have to know how are we, whatever we're doing, is it working? Does the patient have better or an improved symptoms? We have to think about what are the symptoms of heart failure. So that's one of these sheets that I have here. Congestive heart failure symptoms. Because we have to focus on these in order to be sure that we're getting questions right about the medications being effective. Because that's another issue sometimes with this exam. People will, every single medication that we give for heart failure, whether it be if we're giving, digoxin, which increases contractility, if we're working aggressively to bring the blood pressure down, and if we're pulling off extra fluid, all of those medications are trying to make the heart failure better. So they will improve, if they're working, all symptoms of heart failure will get better. So if someone has heart failure, what is the weight? Is there a change to the weight?
Increased.
Yes. So it is increased, and this is an important measure that we use for heart failure. Patients are asked to weigh themselves daily, and they would call us if their weight is greater than 2 pounds, which is essentially about 1 kilogram, exactly, because of fluid retention. So we know, and that means the heart isn't pumping very well. If the heart doesn't pump very well, then we can't filter the same amount of blood in the kidneys. We can't do the things we're supposed to do. So we know that their weight is going to increase if their heart failure is bad. And so if people are taking their medications and following their diet and doing everything they're supposed to do to stop the fluid retention, like you say, then their weight should remain stable. But if they're gaining weight, that means that the medication needs to be adjusted, or we have to ask them, like, did you stop taking your medications? Did you eat a lot of salt in the last couple of days to bring your weight up? What can we do to prevent you from being hospitalized? Because people with heart failure have frequent hospitalization. There might not be many symptoms related to like the brain or dizziness or lightheadedness. Potentially, the heart itself, they might not feel the same things that we would feel if we had a heart attack, right, when we'd have pain and stuff like that. They probably may not feel anything at all. What kind of symptoms will they have in their lungs?
Maybe like a tightness or a tightness in their chest because they've got more fluid collecting around it because the heart's unable to pump it out effectively.
I'm gonna sit for a bit and I'm gonna shower and I'm gonna talk.
Am I the only one that, I mean, I see everybody's talking. I can't hear. Can you hear me?
I can hear you, but I can't hear anything either.
I
I
can't.
can hear you,
But
just
I
not the
can't hear the
teacher.
teacher either.
All right.
It's just the
I just wanted to
instructor
make
that I can't
sure.
hear.
I can't hear her either.
Okay.
Neither can I.
I logged back in and still can't hear her.
Yeah, I can hear you guys. I can't hear her.
Does this mean we get out early today?
Not on this weekend, no.
Not likely.
Can you
So I
guys,
have a quick
guys hear
question.
me now? Can you guys
Oh,
hear
there
me?
you are.
Okay.
Yes.
I do not
Welcome
know what
back.
happened. I was kind of scared because for some reason my computer's camera, like, there's some sort of hardware issue, and then I was like, oh great, now that I have a speaker issue, but okay, good. Did someone have a question though? It sounded like someone was going to ask something.
I did. So I got started a little late taking my notes. So the preload was the diuretic, the conductility was the muscle, the afterload. Which one was that again? I can't remember.
That's okay. The afterload has to do with how we can relax the arteries. So it's a lot of the antihypertensives.
Got it.
Some of those are going to be better than others, which we'll mention. So basically, the newer medications we're going to talk about for congestive heart failure are the diuretics and the digoxin, which
Okay,
promotes
that's what I needed.
contraction.
Thank you.
Sure. So the other thing with lungs is we might hear extra sounds when we listen to the lungs, but they're probably going to mention some of these symptoms we talked about before. There is a potential symptom they could have in their abdomen. Does anybody know what it is?
Ascites?
Yes, you could get fluid there too, so their pants might feel tight. And then for the legs is another place where they can get edema. So, and they might say, okay, that means my socks are tight, shoes are tight. So you have to focus on the things that they will say exactly. It's all from extra fluid. So whatever medication I give, like if I give digoxin, which is not a diuretic, but if it helps the heart pump effectively and move the fluid around better, I will still have improvement of fluid retention, which means those symptoms, like those symptoms I can hear in the lungs and the swelling in the legs, will improve. So put lots of stars by that, because that's part of your reevaluation as a nurse if medications are working. If I used digoxin and the person still had fluid retention, they probably would do both, diuretics too. But I would expect that all symptoms of heart failure will improve with all those medications together. So I'm hoping that the heart pumps better, but the reason I'm doing that is so the person doesn't have backflow of fluid. So that means the symptoms are better. So don't mess that up, because sometimes there's a question, as I recall, since I wrote it, that about digoxin. How do I know digoxin is helping the patient with their heart failure? And people will tend to pick the wrong answer. They won't pick the improvement in lung sounds, but that does mean it's working, because we don't want the fluid to be in the wrong place either. We don't want there to be too much fluid, and we don't want it to be in the wrong place. So that's important. So this is that Word document that I was typing on. So they might not feel symptoms other places, but this is what I want to focus on, because these symptoms should be improved. If the patient is taking their medications and nothing has worsened, they should have improved weight, because the water will hopefully come off of them through their kidneys. Their lungs will be clear and they're going to breathe easier. They'll lose water in their belly if they're retaining water there, and they'll lose water in the legs if they're retaining water there, because the fluid is going where it's supposed to. So it's very, very important, because we got to be sure our medication is working. So when someone takes an antihypertensive, it's less obvious that it's working, because I would have to take their blood pressure to know. But this should be a little bit more obvious in terms of symptoms. And you'll see where I highlighted about calling about the weight. That's very important. If the weight is getting to be 2 pounds extra, that's actually really bad. If they called earlier, that would even be better, which is 1 pound or 2 kilograms. That would even be better. So focus on that too, in case. What does this mean? If the patient calls and says their weight is up, they're probably, their heart is probably not pumping effectively. Okay, so medications. So that's what we're going to do. We're going to try to fix this. So our medications, just like you guys said, if we want to decrease the preload and decrease the fluids, we can use diuretics. If we want to try to get the heart to pump better and push fluid where it's supposed to go instead of getting backed up, in the legs and the lungs, then we can give what are called cardiac glycosides or digoxin. And if we want to make it easier for the heart to pump by decreasing the weight it has to deal with or decreasing resistance, then we can use medications for blood pressure. So hypertension control, we went through those medications last class. Some of these medications are better than others in terms of controlling blood pressure. So if you remember, lisinopril and losartan especially preserved left ventricle function. They were actually heart protective. They stopped the muscle of the heart from remodeling into scar. So those are the best choice. Those renin, angiotensin, aldosterone medications, especially lisinopril and losartan, are the best choice. Except if they can't take it, because why wouldn't they be able to take it? Bum, bum, bum.
Allergic.
As if they've had angioedema to either of those, which is one of those severe allergies, then they can't take it. So we're going to have to try something else. That'd be sad, but we don't want to kill them. Potassium, well, it depends on how high it gets or if they're not compliant with restrictions. There is medication to bind potassium, so it's not like you can't do it, but what is one of the adverse effects of lisinopril that would keep people with certain disorders from taking it? It has to do with the bone marrow. So yeah, angioedema we mentioned with allergy. Lower white blood cell count. Yep, leukopenia I heard someone say. So if they have a history of an autoimmune disorder where their immune function isn't as good, or they're on a medication that also decreases the white blood cell count, they might not be able to take lisinopril, but maybe they could take losartan. So that would be something to keep in mind, because that really is the best though. If they didn't have good kidney function, they couldn't take lisinopril either. So we have to be sure that it's safe, but otherwise that would be a good choice. You could use an alpha beta blocker or a beta blocker, but we have to be careful when we do those. They're only good for the early stages of heart failure because they do take the work off the heart a little bit, which is good if the heart is failing. However, we know that metoprolol also can decrease the strength of contraction of the heart because it's supposed to just change the heart rate, but it can do that too. And so if the person has bad heart failure, we don't really want to give metoprolol. And we cannot use the calcium channel blockers for congestive heart failure because they could affect the muscle function of the heart as well. So the best choice is lisinopril or losartan. Common side effects of antihypertensives. These are some of the most common, like headache and dizziness from the orthostatic hypotension and reflex tachycardia, except for the beta blockers because you can't have that then. So that would be the way we could affect the afterload. We could try to affect the fluid volume in general with diuretics, as you guys had mentioned. So there's 3 classes of diuretics that we're going to talk about. Thiazide diuretics or hydrochlorothiazide, loop diuretics, which is furosemide, and potassium-sparing diuretics, which is spironolactone. So hydrochlorothiazide can be given oral or IV. It is sometimes used for hypertension. It can be combined with some of those other hypertensive medications, and then we can use less of those antihypertensives. So there was a medication we specifically said was sensitive to diuretic therapy that we could bring the dose down. I don't know if anyone remembers that. Boom, boom. Losartan the blood pressure is very sensitive to fluid loss with losartan. So we could actually give less losartan by using a diuretic with it. All of these types of thiazide diuretics have their main issue is changes in how we managed electrolytes in the nephron. So we're getting rid of fluid so the person is at risk of dehydration. So that means we don't want to fluid restrict them. They should still drink normally. We just want to get rid of extra fluid. And they are at risk of dehydration, so we have to be careful there. They would have a low potassium and low sodium, which is different from what we talked about with those renin, angiotensin, aldosterone medications. Those people had high potassium. These people will have low potassium. Potential higher blood sugar and higher uric acid. How would the person know that their uric acid was high?
Kidney stones?
Yeah, gout.
Yes, so it could be that they are retaining uric acid crystals in their kidneys to cause stones, or they're going to retain uric acid crystals in their joints to have gout symptoms, correct? And that's how it would be asked on the exam. It might not say risk of hyperuricemia, it might say patient started this medication and now they have gout symptoms in their foot. You know, you'd have to make that connection. There is an increased risk of renal toxicity if these are taken with NSAIDs. So that's ibuprofen. So we have to be careful if we're taking those together. It's possible this could decrease the effectiveness of some anticoagulants and diabetic meds because here it causes hyperglycemia. So it might mean that we have to be sure the person is checking their blood sugar more if they have diabetes. So this works okay, but it's not as strong as a lot of people need with congestive heart failure. Hydrochlorothiazide is actually better for hypertension than it is for CHF, although you can use it for that. The best diuretic for CHF is furosemide. Its brand name is Lasix. And this medication can be given oral, IV, or IM. And the nice thing about this is we were worried about protecting people with decreased kidney function. That's why we didn't want to take ibuprofen with the hydrochlorothiazide and stuff like that. Furosemide is actually, especially if the person has like a little bit of borderline kidney function, it actually improves blood flow to the kidney. So it's really kind of nice for them, the kidneys. It's much, much more effective than hydrochlorothiazide. So the things that we talked about with hydrochlorothiazide, the low potassium, low sodium, and dehydration are even more something that we have to worry about with furosemide than we had to with hydrochlorothiazide. It has some extra things. Because it can draw so much more fluid, the person could develop orthostatic hypotension. And for some reason, it can sometimes cause ototoxicity. And that means that it could affect the function of the ears, and the person could have decreased hearing. So that is especially an issue if the patient gets IV Lasix and that's pushed too fast. It can actually cause issues with their ears. So you have to be careful. Lasix has to be given over a period of time. It's usually 5 minutes at least, because it's 10 to 20 milligrams a minute. So if you have to give someone 80 milligrams, it's going to take a while to give it. Contraindications, of course, if you're allergic. There's a cross allergy with sulfa. So there are some antibiotics that are made with sulfa, and people who are allergic to sulfa will have issues potentially with Lasix as well. If your kidneys have completely shut down, furosemide won't work. If the person has liver disease, furosemide could become toxic because we need the liver to get rid of it. And NSAIDs decrease effectiveness, like ibuprofen. Can anyone guess why that is? That's a harder question, actually. Just remember, ibuprofen has activity. It blocks the production of prostaglandins that are both pro-inflammation and pro-protection. One of those types of prostaglandins actually improves the blood flow to the kidney. And so if I decrease blood flow to the kidney with prolonged use of ibuprofen, then the Lasix might not work as well. So you notice there's a lot of ibuprofen issues with some of these medications. So keep that in mind. You got to be careful about people when they have to take furosemide more than once a day orally, because you don't want them to take it too late and end up having to urinate all night long. So the reason the brand name of furosemide is Lasix is because the medication lasts for 6 hours. So you never really want to give the second dose of furosemide after 4 o'clock, because then the person was going to be up past 10 if they have a normal or what we say is a normal sleeping schedule, where they're awake during the day and asleep at night. So that's always a test question too. Spironolactone is the last diuretic, and this medication is different than the hydrochlorothiazide and Lasix. Hydrochlorothiazide and furosemide are trying to get rid of fluid by exchanging some of the electrolytes, and they work in a different part of the nephron. Hydrochlorothiazide works in the first part of the nephron, and furosemide works in the loop of the nephron. Spironolactone works at the last part of the nephron. And what it is actually blocking aldosterone. So because we know anything that manipulates the renin, angiotensin, aldosterone system will increase potassium, this medication should pull fluid off, but not cause hypokalemia. So now we have to remember the renin, angiotensin, aldosterone system again. So the body always has angiotensinogen in the bloodstream. Renin is released when the kidneys detect decreased blood flow, which converts angiotensinogen to angiotensin 1. Angiotensin 1 is converted to angiotensin 2 by angiotensin converting enzyme. Angiotensin 2 causes vasoconstriction as well as causes the adrenal glands to release aldosterone, and aldosterone saves sodium and water and gets rid of potassium. So if we block aldosterone, then we're going to get rid of sodium and water and keep potassium. So that's how it works as a diuretic, but that's also how it can cause hyperkalemia. So instead of worrying about hypokalemia like we do for the other ones, we have to worry about hyperkalemia. And the other issue is that it's very like some of our sex hormones, progesterone and testosterone. So it can cause other secondary sex characteristics, especially for women with the testosterone, and it can't be used in pregnancy. So those are our mainstays of diuretics. People usually pick furosemide, but you can use the other two. So we had antihypertensives to bring the afterload down. We use diuretics to bring the preload down, and then we can use digoxin to increase the strength of muscle contraction. And digoxin, the reason I have that picture here is a little trivia for you. So that's a Vincent van Gogh painting. Apparently people used to use digoxin to treat depression, but in far greater doses than they were supposed to. And one of the adverse effects of digoxin is to see more yellow and to have yellow halos. And so that's why people think that Van Gogh painted with lots of yellow, because that's how he actually saw things. So just a little trivia there for you. And it also can cause hearing issues, and so it's possible that that might be actually why he cut his ear off, is because it was bothering him. So some trivia for you. Yeah, share that on a Tinder date. I think that'll totally get you in good. Would you like to hear about digoxin? All right, so here we are, digoxin. So it's called a positive inotrope, which means it's making the heart pump more effectively. It's making the muscle contract better. So that's good. We want to increase the strength of contraction, and it also tries to slow the heart rate a little bit to allow for the heart to fill better. So it's supposed to make the heart more efficient. That's the main use of digoxin. However, it is kind of a dangerous medication in that it has a very narrow therapeutic range, and this is one of the times where you have to memorize the therapeutic range. So it's 0.5 to 2 nanograms. That's a very, very tiny amount. So if we are too low from that therapeutic range, then the person will still have symptoms of heart failure. But if we're too high, the patient will have all these potential toxicities and could lead to death if they develop these bad dysrhythmias. So we have to be sure that they stay within this narrow range. The other thing is, and so students will sometimes look at that range, and they say you had a test question and it said that the digoxin level was 2. Would you give the medication?
Yes.
Yes.
Yay! Yes, you should, because that's in range. Sometimes people are worried about doing that because they're like, oh no, that's the high. It is. I understand your caution, but it's within range. It's a very tiny range. We only have so much to work with. So don't get upset about that. The other issue is potassium. So the medication itself does not affect potassium either way. It's not like the renin-angiotensin-aldosterone system medications, and it is not like the diuretics. It's just that the function of digoxin, the way it's metabolized in the body, changes with alterations in potassium. So if the patient's potassium is low, they are at an increased risk for toxicity. Yes, if the level is too high, the patient would be toxic. So here is an important thing. I can't express enough how much this is important, especially these first ones, which I bolded. We know that lots of medications cause nausea, vomiting, and a change in appetite. And anorexia means a decrease in appetite. We know lots of medications cause that, but this is not a side effect for digoxin. It is the earliest sign of toxicity, followed by headache and those yellow halos and vision changes, and then followed by the dysrhythmias, which could potentially kill the patient. It's better to know that the patient is developing toxicity early. So if the question about digoxin says the patient has nausea, vomiting, or anorexia, your advice to them isn't, that's a side effect, it'll get better. Your advice is, I will talk to the provider, we probably need to get a level to be sure that you're not toxic. And the other issue is that you're always going to want to check the digoxin level intermittently and the potassium level intermittently, because if the potassium gets too low, then the patient is at increased risk of potentially developing a toxicity. So as you can hopefully maybe see a potential problem here, lots of people who have heart failure are on furosemide and digoxin. And furosemide has a high risk of hypokalemia. So we have to be careful that their potassium is okay, so that they don't have toxicity. A lot of times the patient will be on lisinopril, furosemide, and digoxin. The risk of hypokalemia is greater than hyperkalemia. The change in electrolytes from furosemide is stronger than the change for lisinopril. So probably we'll have to see how the patient does. Maybe their potassium won't change at all. Maybe it'll cancel them out. Or maybe the potassium will be low. So you have to watch that really closely. If the person has toxicity, you can give them a reversal agent, which is sort of an antibody. That's what immune fab means. It's a digoxin antibody that binds the digoxin so that it can't affect the body. So you can give digoxin oral with food. This is actually one of the medications you could crush. You have to give the medicine slowly over 5 minutes and be sure the IV is working, because it's what's called a vesicant, which means that if the medication gets into the bloodstream, it could potentially hurt the skin and actually cause what looks like a burn or skin necrosis. The skin could die, so you have to be sure that that IV works before you give it. So if it's a capped IV, that means you have to flush it first, then give it, then flush. If it's a running IV, then you have to just assess that IV site to be sure it's working okay, then you give the medication. There are a few emergency medications for short-term management of congestive heart failure. These medications will not be on the exam, my exam, but they could be on ATI. So just these are medications that are given IV that will help in the short term by increasing heart rate and contractility. So if a person is admitted with a bad exacerbation of CHF where they can't breathe at all, they might go to intensive care and have be on the cardiac monitor and get these medications by continuous infusion until we can get their symptoms under control. But your main medications are the antihypertensives, diuretics, and digoxin. So we filled out the concept map, or we filled out the review the symptoms of congestive heart failure. So now what I would like you to do is, 1 minute, is fill out this medication, CHF medication side and adverse effects, sort of a modified concept map, because it might be hard to do that and scan it. If I'm taking these medications, what are the potential side and adverse effects? You could do it with the colors like I did, or you could just list them. Give this a shot, filling this out, and then upload that into like a non-graded discussion board here, but that's part of your participation.
What is that under?
So the actual, there's a CHF symptoms, which is a blank one where we did the symptoms. CHF medication side and adverse effects is the sheet. And then you can upload it here where it says congestive heart failure. And we'll go over those together. So I'll give you 30 minutes so you have time. So we'll come back together at 11 o'clock and go over a couple of those side and adverse effects, okay? So I will